Welcome to the UNC Core Center for Clinical Research Speaker Series. We appreciate you joining us for today's talk. Our presenter today is Tuhina Neogi, a professor of medicine and of epidemiology and the chief of rheumatology at Boston University School of Medicine, Boston Medical Center. Her presentation today is titled Understanding Pain and Osteoarthritis. Dr. Neogi, whenever you're ready to start, feel free.
Thank you. Thank you for the invitation. I'm sorry it couldn't be in person. We were supposed to have this in April, but I'm at least glad that we can be here together virtually. So I'll start with my disclosures. So before I start talking about pain and osteoarthritis, I wanted to just take a step back and put it into context of why we're interested in pain and osteoarthritis. So over 500 million people worldwide have osteoarthritis, according to the latest global burden of disease estimates, representing about 10 to 15% of adult populations. The knee is a very common site for knee osteoarthritis and knee pain. And in the US, about 30% of adults report experiencing pain in the prior 30 days. We know that the pain can initially be intermittent and activity related, but over time, the pain severity can increase and the pain can become more persistent. Not surprisingly, perhaps, joint pain and arthropathies are now the #1 reason for ambulatory care visits in the US. This is ahead of things like hypertension, which obviously patients don't go to see their doctors for hypertension because they're feeling something. It's because the doctors are telling them to come back for their blood pressure checks. So in terms of what's important to the patient, they are going to their physician because of joint pain and arthropathies, of which osteoarthritis is a large contributor. Musculoskeletal pain is now the second leading cause of years lived with disability worldwide. And again, osteoarthritis is a large contributor. And osteoarthritis as a diagnosis is the third leading diagnosis for hospital discharges. And this is #3 after childbirth-related hospitalizations and sepsis-related hospitalizations. So for those of us that are physicians, this might seem very surprising because we would think that heart attacks and congestive heart failure admissions are more common, but osteoarthritis is the third leading hospital discharge diagnosis, reflecting the huge volume of joint replacement. And so we understand that pain is the primary clinical symptom of osteoarthritis. And because we don't have disease-modifying agents, our focus is really on pain management in osteoarthritis presently. Compounding the issues of the large prevalence burden is the fact that people are living longer with knee osteoarthritis, meaning they have decades of symptomatic disease that need to be managed. Unfortunately, we have very limited management options. While exercise, physical activity, and physical therapy and weight loss are all effective measures, they are woefully underutilized. And of the pharmacologic agents that we have very few options with minimal to moderate efficacy and a number of concerning adverse effects and contraindications, which affects often more so older adults who are more burdened by osteoarthritis. And then the definitive therapy for end-stage disease is considered joint replacement. But about 20 to 30% of people continue to have persistent pain post-knee replacement. And there aren't enough orthopedic surgeons in the country or in the world to perform the millions of procedures that would be needed to address osteoarthritis. So with that context, let's talk about pain and osteoarthritis, and I'll start with causes of pain and osteoarthritis. So a key question in osteoarthritis is whether or not structures contribute to pain. We understand from pathologic specimens and from MRI that osteoarthritis is more than just a disease of cartilage and bone. It's a disease of the whole joint affecting all the tissues. So we do have some empiric evidence that pain does emanate from structures within the knee. We have evidence, as an example from this trial, of an intervention of local anesthetic injected into the knee. And the knees that had local anesthetic injected had a pain reduction down to 0. Whereas in the intervention arm, in the placebo arm, where only placebo or saline was injected, there was no pain improvement. So this suggests that there is something within the knee that is responding to the local anesthetic. And for those of you who've heard me speak before, you know this is one of my favorite studies. This is a study by Dye et al., actually two brothers, two orthopedic surgeon brothers, where one brother performed an unanesthetized arthroscopy on the other brother. And so there's a whole host of family dynamics there that we don't know about as to who was performing this on whom, but they basically interrogated tissues in the joint and rated the pain as being 0 for no sensation to 4 being severe pain. And not surprisingly, tissues that we know to be painful, such as the infrapatellar fat pad, ligaments, synovium, were all painful. The outer aspects of the menisci were painful. And not surprisingly, healthy cartilage, which is largely aneural, was not painful. They didn't interrogate bone, since we know that that's painful. So despite those those examples where we can show that there are painful structures in the knee, we have this so-called structure-symptom discordance in osteoarthritis, wherein there are some knees that have pain, but not much radiographic OA, some knees with radiographic OA, but not much pain, and the overlap between pain and radiographic OA is not complete. So why might this be? Well, we understand much better now that pain is multifactorial, regardless of what disease you're talking about. And so for those that are clinicians, you'll recognize that if we don't address psychological factors such as sleep, mood, coping, catastrophizing, no matter what we do elsewhere, that we're not completely address the pain issues if we haven't helped address these issues. And so we have a number of different factors that contribute to pain, making it difficult to disentangle the effects of joint pain on OA pathology. And it's hard to adjust for all these factors when you actually don't even know what all the factors are to adjust for. And so we took an approach where we tried to eliminate those between-person confounders by looking at people who had pain in one knee and no pain in the other knee. And in this way, all those between-person variations in the pain experience is inherently controlled for. And if there are differences in pain in the knees, it must be due to something going on in the knees of that individual person. And when you do this type of analysis, you see that as radiographic severity increases, so too does the risk of having pain. And we did this in 2 different cohorts. So there's definitely is a strong structure symptom discordance, including at the earliest stage of radiographic OA at Kellgren and Lawrence grade 2. So what are the lesions that are contributing to pain in osteoarthritis? So radiographs are not specific enough to provide such insights. In this study by Martin England in Lund, when he came and visited us in Boston, he used data from the Framingham osteoarthritis study. And he took individuals in Framingham who had radiographic evidence of osteoarthritis and divided them among people who had frequent knee pain and versus those who did not. And in these groups, he looked at how many had meniscal tears versus no meniscal tears. And he found that the frequency of meniscal tears were about the same in people who had knee pain versus those who did not. So really, for the first time, calling into question the relevance of meniscal tears in symptoms of osteoarthritis. And then extending this study, Ali Gormazi also looked at the Framingham osteoarthritis study, this time limiting it to those with no radiographic osteoarthritis. And what was really interesting is that in these knees that had 0 radiographic OA, almost 90% had some kind of an abnormality on the MRI. And that the frequency of abnormalities were same in the knees with pain as in the knees without pain. But then looking at specific pathologies, bone marrow lesions, subchondral bone attrition, and subchondral cysts were associated with pain. And this is findings that have been replicated in other studies. So despite these kinds of findings, we know that a whole host of effort has been exerted in osteoarthritis in chondroprotection. And to date, we don't yet have any agents approved for chondroprotection, though there are a couple of agents that are being tested now that show some potential benefit for chondroprotection, but perhaps not yet for symptoms. And the FDA does require for DMO designation structure and symptom benefit. There are some therapies that have been directed against bone marrow lesions, such as bisphosphonates with variable responses, overwhelmingly though negative, and also a patellofemoral knee brace study, which did show reduction in patellofemoral bone marrow lesions. Synovitis and inflammation have also been studied. Most commonly, we think about intra-articular steroid injections as addressing synovitis and inflammation with only short-term benefit. And then for the meniscus, we have now a better understanding that meniscal lesions may be a feature of osteoarthritis, and that these are generally perhaps degenerative tears as part of OA pathophysiology, very distinct from those acute meniscal lesions in athletes when they have a specific knee injury. But the therapy that has been most widely used for this is arthroscopic partial meniscectomies, which are among the most common orthopedic procedures in the US, about 700,000 per year, despite numerous clinical trials now, well-conducted numerous clinical trials demonstrating really no difference in efficacy of APM versus either sham or placebo or usual care. So we have a long way to go, and that was just a little side diversion before coming back to pain and OA. So I've just outlined how all of these different factors contribute to the pain experience, and unless you control for them, you won't really understand the structure-symptom association. But that got us interested in actually understanding what some of these other factors are that are contributing to the pain experience. And in particular, over the past decade, we've spent time studying neurobiological mechanisms contributing to OA pain. So why are we interested in this? Well, we know that there are nociceptors in joint tissues, and they provide an appropriate response to initial joint injury. However, over time, the pain in OA can become chronic and persistent, and is thought to no longer reflect pure nociception. And clinically, we recognize that initially people might have very localized pain, but over time in later stages, they can have a much wider range of pain and referred pain. So again, no longer reflecting pure nociception. So these observations indicate that altered neurobiological pathways may play a role in OA pain. So first, tackling this question of neuropathic pain in osteoarthritis, and I show here a picture of Dr. Priyanka Bilal, who's one of our rheumatology fellows. So we were interested in assessing the role of neuropathic pain in OA because there have been a number of self-reported questionnaires, including Pain Detect, that have reported a prevalence of anywhere from 5 to 30% of neuropathic pain in osteoarthritis. But these questionnaires have never been validated against an objective measure of neuropathy. And so we worked with Clifford Wolf, who was the person who first described central sensitization, and one of his mentees, Joachim Schultz, to implement a validated set of bedside tests to assess neuropathic pain versus non-neuropathic pain. And this includes things like von Frey monofilaments, using a brush for dynamic allodynia, etc. And when we did this in the multicenter osteoarthritis study, we did this in about 18 to 1900 participants before we stopped doing this, because we found that less than 3.5% had any objective sensory testing abnormalities. And this was irrespective of whether or not the knee had osteoarthritis or if the knee had pain. Instead, what we found is that if people had diabetes or low back pain suggesting radiculopathy, then we could start to find higher prevalence of these abnormalities. And so those self-reported prevalences of up to 30% was not something we could detect with these objective measures. And while we acknowledge that we did not do nerve conduction studies or EMG, these are standard tools that neurologists use to pick up neuropathy. And so I think what this highlights for us is that someone's self-reported descriptors does not necessarily translate into objective mechanisms. Okay, so if it's not neuropathic pain, then what other neurobiological mechanisms should we consider? And so those of you who have seen my talks before know this is my crude attempt at illustrating the nervous system from the periphery all the way up to the brain. So peripheral sensitization refers to alterations in peripheral nociceptors, making them more sensitive to stimuli. Central sensitization is a similar phenomenon in the central nervous system. So either one of these increase sensitivity to stimuli and are considered ascending facilitation. Then there's inadequate descending inhibition or descending modulatory pathways that help dampen those pain signals. And abnormalities in any one of these pathways, any abnormalities in functioning of these pathways can lead to heightened pain sensitivity. So what is the evidence for central pain mechanisms in osteoarthritis? Well, going back to that trial that I showed initially, where local anesthetic was injected into the knee and showed symptom benefit, interestingly, the contralateral knee also had pain relief. So why would this be if you're injecting something specifically into one knee? Why would you get a pain improvement in the other knee, suggesting that there's some central control of this? Now, the assessment of neurobiological mechanisms can be done with direct evaluation of nerve activity through electrophysiology. So you can look at nerve activity by directly interrogating the nerves. And years ago when I used to go to present our data, I would often get questions about why we're not simply interrogating the nerves. And I have to remind people that these are useful for animal models, but we're studying humans. And we can't really interrogate the spinal cord or people's nerves with big needles. So what do we do clinically? Well, we use quantitative sensory testing, or QST, as a proxy for trying to understand the functioning of these systems. So in osteoarthritis, we tend to use pressure pain threshold, which is a mechanical stimulus, because OA is largely biomechanically driven. So we think that this is a relevant stimulus to assess in osteoarthritis. Lower values reflect greater sensitization. So as you're applying the algometer, if someone feels the pressure changing to pain more quickly, that's a lower threshold, greater pain sensitivity. When we test it at the patella, we think of that as reflecting peripheral and or central sensitization. And when we assess it at the wrist, which is a site distal to a diseased joint, and the wrist is typically not affected by OA, that is just a central sensitization. Now, for mechanical, another way to assess central sensitization is mechanical temporal summation. So again, another mechanical stimulus. Here we use a series of weighted punctate probes that we apply to the skin at a regular interval. And if you remember how your action potentials are supposed to work, each time you apply a stimulus, you get an action potential. And if you keep applying the same stimulus, you should get the same action potential. So a normal person would have just a flat line of pain ratings, whereas someone who's sensitized has ascending facilitation with central sensitization, that pain rating will go up over time. And then finally, conditioned pain modulation, or CPM. This assesses the descending inhibitory modulation or the dampening effects. And there are a number of protocols, but the one we use is, again, with pressure pain threshold. Then you apply a painful conditioning stimulus, and then you test the pressure pain threshold at the same site again. If that dampening effect works, then the second pressure pain threshold should be higher than the first pressure pain threshold, and this can be assessed as percent efficiency. So I'll just show you some examples of studies that we have conducted with these QST measures. So in MOST, which is a cohort of 3,000 older adults with or at risk of knee osteoarthritis, we assessed pressure pain threshold at the knee and at the wrist. And what we found is that lower pressure pain thresholds, again, more pain sensitivity, were significantly associated with more knee pain severity and frequent knee pain, and a similar effect at the wrist. So pressure pain threshold was associated with pain severity at the site of and distant to pathology. And this was adjusted for all potential confounders, including degree of radiographic OA severity. Temporal summation, we've had a similar finding where presence of temporal summation was associated with pain severity. Interestingly, We did not find any association with radiographic OA, which was contrary to our hypothesis, because we thought that the more severe OA would lead to more temporal summation. And this finding has been replicated by other groups, that it's really pain severity that seems to be associated, not radiographic severity. Nonetheless, we wanted to understand if specific pathologies contribute to sensitization, since radiographic severity is not specific enough, is not sensitive enough for us to truly understand what's going on at the joint level. So in animal models, you can induce sensitization through a joint injury, sort of mechanical stimulus. And so in humans, the equivalent would be bone marrow lesions in osteoarthritis. And in animal models, another way to induce sensitization is through inflammatory lesions. And in humans, so chronic inflammation. And so in human OA, synovitis and effusion would be reflective of inflammation in OA. And what we found was that bone marrow lesions were not associated with sensitization, whereas the inflammatory lesions were. So while bone marrow lesions are associated with pain in osteoarthritis, the mechanism by which they do so, it does not appear to be through sensitization, whereas synovitis and effusion, at least in part, contribute to pain through sensitization. And then I'm just going to show you some recent data that we just presented at ACR, where we wanted to look at whether or not, in addition to just cross-sectionally being associated with pain severity, do we have association with new or worsening pain. So here we have in the red circle incident frequent knee pain, incident intermittent or constant pain using the ICOPE instrument, and pain worsening with WOMAC. And on the x-axis, we have the various QST measures, with these three measures reflecting the ascending pathways and condition pain modulation reflecting the descending inhibitory modulation, modulatory pathway. So broadly, these ascending pathways were associated with an increased risk of developing frequent knee pain or intermittent or constant pain or pain worsening, at least one or more of those outcomes, whereas condition pain modulation was not significantly associated with any of those outcomes. And then I just want to highlight a work that Lisa Carlesso did with me when she was a visiting postdoc on pain susceptibility phenotypes. What we really wanted to understand is whether or not there were features that clustered together in individuals that predispose them to developing persistent knee pain. So we know for some people with osteoarthritis, they just have weight-bearing activity-related pain. And then for other people, they develop more chronic persistent pain, and why that happens, we don't know. So we were interested in factors other than pathology that might predispose people to going on in one pathway versus another. And so we looked at factors other than radiographic severity, as I mentioned, and we were interested in things like depressive symptoms, sleep, widespread pain, catastrophizing, in addition to our QST measures. And so we started off with people who were free of persistent knee pain at baseline, and we followed them longitudinally over 2 years. So we used latent class analysis to agnostically identify whether or not there are any clustering or grouping of these factors. And we identified 4 clusters or 4 classes. One of the classes was largely dominated by having low pressure pain threshold at a number of different sites. Another group was largely dominated by having temporal summation. And then the other 2 groups had lesser degrees of sensitization. What really surprised us, though, was that there was no difference between the groups on widespread pain, pain catastrophizing, depressive symptoms, or poor sleep. We thought that these factors may cluster together or cluster in different ways that would predispose people to pain, but these did not differentiate between the 4 classes. So then when we looked at these 4 classes, again, people free of persistent knee pain at baseline, and looked over 2 years as to who developed persistent knee pain, we found that the group that was represented by low pressure pain threshold at different sites, had a twofold increased risk of developing persistent knee pain over time, suggesting that this might be an actual inherent trait in some individuals, predisposing them to their pain phenotype as opposed to a state induced by pathology. So I just showed you a lot of data, but to summarize, for our QST studies, we showed that these pain sensitization measures are associated with pain severity, and irrespective of radiographic severity or duration. But there are specific pathologies, specifically synovitis and effusion, that are associated with sensitization. And then sensitization, particularly ascending facilitation, appears to be associated with development and worsening of pain, as well as pain susceptibility phenotypes. And then I'm just going to end with one last example in which we looked at post-knee replacement. So 2 decades ago, this was first demonstrated in a post-hip replacement sample, a very small sample. And then about 8 years ago, this was replicated in a post-knee replacement sample. So what we're talking about here is this descending modulatory inhibition pathway. And remember that low pressure pain threshold reflects more pain sensitivity. So in this study by Graven Nielsen et al., they took 20 subjects with OA and 20 healthy controls. And what you see here for the healthy controls, and I should say healthy controls means people without OA and without pain. So when they applied the pressure pain, when they assessed the pressure pain threshold, they got a certain measurement. And when they assessed pressure pain threshold after applying the painful conditioning stimulus, as expected, that dampening was working, and the second pressure pain threshold is now higher, so less pain sensitive. In contrast, those with a knee OA awaiting joint replacement did not have the expected modulation, but interestingly, post-knee replacement, they did show normalization, suggesting reversibility of these neurobiological mechanisms, and we know that there is neuroplasticity. However, an issue is that this is a very small sample, and all 20 of these OA subjects had pain improvement post-knee replacement. And you'll recall I had mentioned that 20 to 30% of people continue to have persistent pain post-knee replacement. So we were interested in understanding what happens if you include people who also did not have a good outcome post-knee replacement. Does this normalize? So one of my postdocs, Dr. Kosaku Aoyagi, who looked at this in the MOST study where we had a sub-cohort of people post-knee replacement, we found that post-knee replacement presence of temporal summation and inadequate condition pain modulation were associated with worse WOMAC pain post-knee replacement, suggesting that, again, central mechanisms are contributing to that pain persistence post-knee replacement. And of course, acknowledging that there could be a number of other factors contributing to those symptoms, but at least some portion of that is contributed by these mechanisms. So what does this all mean for the future of osteoarthritis pain management? I think what I hope these series of studies have shown is that as osteoarthritis researchers and physicians managing osteoarthritis, we need to think beyond the joint about these other potential contributors. I think many of us already try to address sleep and mood and catastrophizing and coping skills, etc. But we also now need to more carefully consider these pathways. And fortunately, there are some agents that do target these pathways peripherally and centrally, but they often, many of them often have poor efficacy or poor tolerability or side effects. So there are a number of emerging pain targets, and of course you are all familiar with nerve growth factor and TRK inhibitors. So probably early next year we'll hear about whether or not any of these agents will be approved. TRPV1 is another receptor that we already use clinically with topical capsaicin. So topical capsaicin, capsaicin is the active ingredient in hot chili peppers. So for those of you that might be like me, where I like to eat hot chili peppers, you get that burning sensation, and that is reflecting the sort of release of those neuropeptides that lead to pain, and then eventually, once those nerve terminals are depleted, you get analgesia. CGRP and substance P. So CGRP is interesting because there are approved agents that are anti-CGRP, have an anti-CGRP mechanism that are approved for migraine. And just anecdotally, there have been patients that have migraines that have been on their anti-CGRP therapy that then find their musculoskeletal pain has improved. MCP1, CCL2, this is really interesting, and a lot of work by Anne-Marie Malfay on this pathway. There are ASICs, or acid-sensing ion channels, voltage-gated channels that are all in development. And being tested in osteoarthritis in particular are many of these. And I did not mention the CB2 cannabinoid receptors and some other pathways. But also in this review, they put this pathway in the structural DMOD category figure, but ADAMTS is also a potentially promising target for pain sensitization. So a lot of activity in osteoarthritis, pain agents being developed. So now to a couple of philosophical questions. Should we completely ablate nociception? So we know that nociceptive pain is needed to a certain extent to prevent harming oneself. So if you touch a hot stove, you immediately pull back your hand so as to not further injure yourself. When you go running, if you twist your ankle, you kind of limp and kind of offload that joint to allow it to heal. So we know that osteoarthritis pain, or any arthritis pain, is not like other pathologic pain conditions. This is not the same as diabetic painful peripheral neuropathy, not the same as postherpetic neuralgia. In those neuropathic pain conditions, the pain is not serving an important biologic safety signal. Whereas we know that in the joint, we need to have some of those nociceptive safety signals. We know what happens when a joint is insensate. We know about Charcot joint, so that's not truly nociception, that's proprioception, but similar idea about affecting the sensation in the joint. And then there's this so-called analgesic hip, reflecting findings in a trial of an NSAID versus placebo, where the NSAID arm had greater pain improvement, but they also had more joint space narrowing, calling into question the possibility that with analgesia, you might overload the joint, and that might be detrimental. So when I talk to patients about pain management, I tell them that zero pain is not the goal. And in fact, I do try to spend some time explaining that we do need to maintain a certain degree of nociception. So what we're trying to do is take care of that maladaptive pain, the malfunctioning pain information that is the patient is experiencing that is not useful for joint functioning. And what we're aiming for in management is to allow them to function, to do what they want to do, and to have a good quality of life. The goals of therapy are not zero pain, but rather how to manage that pain so that they can function to the best of their ability. So in summary, I hope that I've shown some data to support our need for having better objective tools to identify actual mechanisms operating in a given patient to better tailor therapy, rather than trying to use a one-size-fits-all hierarchy of try this, then try that, then try that. We ideally want to move to a mechanism-based approach to treatment. I've also shown you some data that supports pressure pain sensitivity, and specifically ascending pain facilitation, as being a potentially important driver of developing or worsening of knee pain, and in particular, a role in pain susceptibility phenotypes. And this has broader implications beyond osteoarthritis in understanding the transition from acute to chronic pain. And then finally, I didn't have time to really go into this, but I think we need to disentangle radiographic stage of OA, or stage and duration of OA from stage and duration of pain. They may not be fully in parallel tracks, and that might inform us as to appropriate timing for joint replacement, which type of therapy to use, etc. So again, going back to a mechanism-based approach to treatment. And with that, I'd like to just acknowledge grants for this work that I've presented, and I'd be happy to take questions.
Thank you, Dr. Neogi. Just to remind everybody, you can ask questions in the chat. If you want to type it in, I'm happy to read it out loud, or you can unmute yourself and ask the question.
That was a great talk, Tuhina. I can get started with some questions. In clinical trials, even for structure modifying drugs, we use primarily WOMAC pain as the outcome measure. And as you've probably seen for some of these structure modifying trials, there's some improvement in structure, but not much in terms of WOMAC pain. Should we start using some more objective type of pain measure rather than just self-reported pain? And if so, which measure would you use? And have you seen trials doing this yet?
Thank you for that question. Yeah, this is, really, I think, near and dear to many of our hearts, seeing numerous DMO trials failing on showing the structure side of things. And in contrast, recently, DMO trials failing to show benefit or efficacy on the symptom side of things. I think one of the challenges for me and people who've joined the OA study groups in the last couple of years, we've had this ongoing discussion. Are we using the right instruments for symptoms, particularly for these long-term trials of 3 to 5 years? We know that patients often accommodate to their, to their pain experience. So they alter their functioning, they alter their activities, or they alter their frame and anchoring. So what is a 4 out of 10 today, 5 years later, it does not mean the same thing. So I think that's one issue. I don't know that we have data to suggest that WOMAC is fit for purpose. In addition, with the trajectory analyses work that many groups have done, you see these tremendously flat trajectories over multiple years, whereas as clinicians, we know that that's not the case for many of our patients. So I think that's one concern. Grace Lowe, several years ago, published a paper on trying to adjust WOMAC for physical activity. I don't know that that's necessarily been further assessed over a longer period of time to see if that's any better. But to your question about objective measures, I have not seen any studies looking at these types of objective measures. Whether or not they perform any better over a longer period of time, we don't know. We now have data in the MOST study where we can look over, let me just think about this, doing the math quickly, 7 to 9 years where we've repeated these measures. And so we can look at those changes over time. And we are in the midst of doing some analyses right now, looking at minimally important differences in pressure pain threshold to see if it, but the problem is, what's our gold standard? So our gold standard in those analyses is going to be WOMAC pain. But I think another important role that these measures play in trials is understanding pain phenotypes and understanding mechanism. So, for example, if we just take the ADAM-TS target, if it works, and unfortunately some of the early readouts have not been promising, but if it works, if we could show that someone's going to have a better pain response if they have low pressure pain threshold, or they have temporal summation, or they have inadequate condition pain modulation at baseline, then we can use that as a stratification for who's appropriate for a particular agent. And or we can use the data to understand whether or not the purported mechanism is truly operating for that target. So I think there are two reasons to try to use these. And I've been for many years trying to convince some of the pharmaceutical companies in the field, particularly for the pain agents, to use these objective measures, but there have been no takers so far. I would say that pressure pain threshold is the easiest one to implement and the highest reliability.
And I think the companies might also be worried about FDA approval, because I think the FDA still requires a patient-reported outcome, right, for approval. So, yeah, so maybe the FDA has to get involved in this, you know, working with people like you in terms of better outcome measures. Yeah, but thanks for that answer.
This is a little bit of the sort of chicken and the egg. So first of all, I completely agree that, you know, you have to do the PRO, but they could do this as an exploratory. They have like hundreds of measures that they put into trials, and this would add 2 to 3 minutes. You know, so it's not very onerous. And in addition, so I think this was 2 years ago at ACR, where there was the OA phenotype and pain phenotype session. It was sort of the chicken and the egg. We have to validate it by putting it into trials, but the trialists don't want to put it in unless it's validated. So we're in this, like, there's a hole in my bucket, dear Liza situation with this.
Yeah, yeah. Well, thanks. I don't see another question yet, but I have another one. I'm really interested in the pain stuff that you're doing, and I would like to get your opinion on the anti-NGF and rapidly progressive OA. You know, as you know, it seemed to be people that were taking NSAIDs plus anti-NGF that were at higher risk. Is that something related to like the analgesic hip story in the knee, or maybe there's some biology between blocking NGF and blocking prostaglandin production that caused rapidly progressive OA? I mean, I know there's not an answer, but I'm just curious if you have any insight into that, because it's going to be an important question if these things do get approved.
I think you probably have more insights into the biology than I may, but it's exactly right. Is it overloading a previously underloaded area of the joint in a deconditioned limb, so you can't adequately protect the joint when you have adequate analgesia? And we know Tom Schnitzer and Tom Andriaki years ago showed increased knee adduction moments with NSAID associated analgesia. So is it that? I was on the FDA during this whole time of the reviews, and unfortunately back then the companies, first of all, number one, they went into these trials without adequate plans for imaging, and they didn't have any formal physical activity evaluations. So while there were some anecdotes from some sites, well, like someone said, oh, I went out dancing, and oh, I can play tennis again, the information that the companies had was that they didn't seem to see increased physical activity. And that's not surprising to anyone here. We know that physical activity is largely behaviorally motivated. So pain relief may not alter physical activity, but it could alter joint biomechanics. So that was one thing. Another is the companies were saying, well, the mean pain improvement was no different among those that had an adverse joint event versus those that did not, trying to argue against this analgesia issue. But, I still am suspicious about not physical activity. I don't think people are becoming more physically active. I'm still suspicious about altered biomechanics in these people have had painful OA for many years. Their limbs are deconditioned. They may be now just slightly altering where they're loading previously underloaded areas. Plus, on top of that, probably a susceptible joint. I do think there's some biology here. I don't know if any of you have looked at the FDA meeting images from 2012. this is not subtle RPOA type 2. It's complete joint destruction, complete subluxation. That is not just going to be from overloading the joint a little bit. So I do think there's some biology there as well. And Tanya Vincent and David Walsh and others have provided some insights into the biology. But Rich, I would defer to you for those insights. So I think what's, even with the risk mitigation strategies, there's still, some findings. Now, what I will say is the RPOA type 1, I'm not 100% sure how to interpret that and really how often that's occurring, because RPOA type 1 is simply a joint space width measurement issue. And we know that it's highly susceptible to positioning. So I'm not sure how we can really have confidence that all of these sites across the world adequately positioned these x-rays to really measure joint space width. On the other hand, there is a difference between treatment versus placebo. So there's something going on. One of the things I think we will come to find more about is that once the FDA hold was lifted and they resumed their programs, they were getting MRIs. So we're going to have a much more insights as to how much that joint space width change is corresponding to actual changes in cartilage, or is it, again, overloading and now there's more meniscal extrusion, so the joint space went down. I'm still concerned about wanting to understand the risk factors and phenotypes. So is it someone who has osteoporosis and was on a bisphosphonate and didn't have adequate bone remodeling, or something that predisposes them? And so it's like multiple pieces that have to come together in this puzzle to have an adverse event.
Okay, yeah, great. I think that's a really good answer. I agree that there's a biology component to it as well, but that's not understood either. So we do have a lot to learn, but the MRIs are interesting. I didn't realize they were requiring that in the trials. So looking at other tissues and seeing how they might be affected by anti-NGF, would hopefully be useful.
Yeah. I just want to cite, I can't remember the author right now, unfortunately, but there was an animal model study where they showed something about NGF and TRK receptors in the bone.
Yep, they're
causing a difficulty in that. I think it was a mouse model or something. It was a fracture, and there was impaired, I can't remember if it was a fracture or just strain on the bone, but the inhibition of that NGF-TRK interaction impaired fracture healing, or somehow the bone's response to that mechanical strain, something about that. And I think that is kind of a compelling story to put it together with how to explain RPOA type 2.
Yeah, yeah. Thanks.
Hi, Tuhina. I have a question.
Hi.
Well, thanks for that presentation. I admittedly don't understand pain pathways very well, and so I really appreciated your simplified model about how these different quantitative sensory testing relate to the different parts of the pathway. And I'm going to try to ask a question for a student that's been working with Yvonne and I, who I know couldn't be here live but is planning to watch this recording later. He's doing an analysis looking at some quantitative sensory testing in JOCO, and consistent with what you reported, the pain pressure threshold was associated with pain severity, but we're also looking at some vibratory threshold, which seem to be more consistently associated with the other OA outcomes. And so I was wondering if you had any comment on other sensory testing like vibration and its association with OA outcomes.
Yeah, that's a really interesting area, and Naja Shakur is sort of the expert in this at Rush University. So if you look up her papers, so in most, so she's done some local smaller studies at Rush, but she also, in the second cycle of most, we had included VPT as well. And then there's a paper that she and I did with Anisha Dua as the first author, where we tried to piece together PPT and VPT together. So yes, VPT has been associated with more radiographic OA severity. so uh, so we were trying to see what, if you have a combination of VPT and PPT, what would it do for your associations with OA outcomes? And the results were not what we were expecting, and it was hard to explain. And now I don't remember the details offhand, but I think what we found is that people who were more pain sensitized had a low PPT. They also had a low VPT, like they could sense the vibration sooner. So that kind of makes sense. But but it also kind of didn't make sense because those were also people who had more pain or something like that. So I would encourage you to look at Anisha Dua's paper. It was challenging to put it all together, and it took us a little while to get it published because the findings were so challenging to put together. But I think, you know, in retrospect at the time, we didn't really think about separating out nociception from proprioception and sort of thinking about it in that way rather than trying to make a mishmash of hypothesis for it.
Great, thank you. Yes, I think that is on our radar, and we are also having some problems trying to piece it all together. So I appreciate that.
Tuhina, this is Lee. In the Johnson County, when we've looked at mortality in people with knee and hip OA, we've found that people with pain in either the knee or the hip have increased mortality. People with pain without radiographic symptoms. So we found that increased mortality in people with symptomatic OA, and then similar increases in people with knee symptoms. And that's way above the people who have radiographic OA without symptoms, sort of in that first Venn diagram you did. And so what do you think, do you have comments about sort of why people with no radiographic symptoms would have increased mortality just because they have pain? And do you think certain pain phenotypes that you've looked at might, if you sort of were able to be more granular with those pain groups, could you find even sort of a differentiation?
And something that I'm really interested in looking at in the MOST study, now that we have 7 to 9 years of follow-up, and this is an older cohort. And I also have 2 grants in the Framingham heart study for the offspring cohort and the 3rd generation cohort, looking at pain for a variety of things, but one of my outcomes is mortality. And I'm also doing this in Jackson Heart study, which is an African-American cohort in Mississippi. So there are studies that have shown chronic widespread pain are associated with mortality. This is, you know, largely work by Gareth Jones and John and Macbeth in the UK. And they also used UK Biobank to look at this. And that's irrespective of what the underlying cause of pain is. And sort of the more sites you have, the more functionally disabled you are. So, you know, is it because of the pain that they're functionally limited and they're not, you know, walking as much, et cetera, et cetera? Is that the pathway? Or is it that when you have pain, regardless of why you have pain, there might be increased low-grade inflammation, increased low-grade kind of stress responses in terms of heart rate variability, blood pressure, et cetera? It's not clear. So this is you know, these observations have been made across different groups. And other than functional limitations, walking disability, no one has really, as far as that I know, I haven't done a thorough search more recently, but no one's really identified another factor that is either, you know, sort of causal or a mediator to explain this.
Yeah, we've talked a little bit about the inflammation in our group too that you've mentioned, but I just wondered if you had any other insights as to possibilities.
Functional limitations, walking disability, that's been,
yeah, well, that's what we thought too. Yeah.
Yeah. But yeah, so the other thing is that widespread pain is not the same as pain sensitization. So, I think we have opportunities to try to disentangle these and see if there's synergistic or additive effects of having sort of different types of pain phenotypes, as you were saying.
I think the pain stuff in the Johnson County came in. There are not as many people as, sort of the whole cohort that had the pain sensitization.
Great talk. I was really interested at the end there when you were talking about, increasing loading on a previously unloaded joint. It's exactly what we see in our post-traumatic group, where early after injury, their Q scores, their symptoms, even their MRI are associated with early underloading, and then we see it switch, years later, where greater loading during gait is associated with some of their worse symptoms anyway. So that's really interesting. I guess I have a question. I love that study too with the two orthopedic surgeons. I think of it in their garage, doing this arthroscopy. And one of the things that strikes me about that is how the fat pad is always the most sensitive area. And it's this, neuroendocrine organ, right? And I was wondering, that's also the area where with arthroscopy, they put their portals when they do a lot of these surgeries. And I was wondering if you've seen any influence of previous history of knee surgery or arthroscopy on or lower, I guess, pain pressure thresholds.
I don't know. I can try to look at that in our data because we do have knee surgery information. But yeah, that's a great question. I actually never thought about where the arthroscopic probes go in. I have thought about this with regards to post-knee replacement pain, because not every surgeon has not every surgeon does the same thing with the infrapatellar fat pad and the synovium. And I tried to study that in my post-knee replacement cohort. Unfortunately, surgical reports were all over the place, and I couldn't tell if it was resected or not. So I haven't been able to analyze that.
Yeah, I was shocked by how much they resect it and don't necessarily think much about it. The other thing that we've seen with some of our MRI, and when we were first looking at it, like the fat pad, there were these artifacts in it. And I was asking some of the radiologists what that was, and essentially they're saying with their boring, they leave microscopic, metal pieces that oftentimes will get stuck in that fat pad, but it shouldn't really matter for anything. And I thought, I wonder if it has anything to do with, that pain that people have right after surgery that, can last, years and years. But thank you.
We're over time, but I did want to just say sort of something again with that overloading a previously underloaded joint. I also wonder about not just increased loading in a previously underloaded joint, but the specific areas, if the location of loading might alter a bit onto areas of previously relatively underloaded cartilage. And then secondly, will we need to think about prehabbing before giving substantial analgesia?
Yeah, I think your point is well taken, because oftentimes when people underload or have decreased force, they also, along with it, have a stiffened knee gait, right, where they would have less movement of the bones across the joint surface. So it could increase that, The other thing that they have with underloading, which is interesting, is they often have a more sustained load across the surface. So even though it's a less overall load, they don't have the dynamic load, underload, load again. So I think there's a lot which could mean that they might have higher loads, even though we're measuring lower loads in those areas, which I think is difficult to explain. But.
Know all the proper terms of contact stress and shear, but I do think that there's probably, if you don't have the good musculature around the joint and this and that we might not have the best way to measure it all, but maybe finite element analysis or DEA or something might help get at locally what's happening within the joint at specific areas.
So I know that we're over on time, so if anybody has another question, feel free to ask it, or you can also email me and I'll make sure that it gets to Dr. Neogi. I'd like to thank you again, Dr. Neogi, for taking the time to talk to us today. I'm going to be sending everyone a follow-up email with a link to access this recording in case you'd like to listen to it again or to share it with colleagues. Again, prior to everyone leaving, we ask that if you could complete a brief anonymous poll about the presentation. It just helps us with future planning on how to organize all of these presentations. So I'm going to stop the recording and then I will launch that.